Welcome to the deep dive. Today we are looking into something really fundamental, our vision. We're going deep on vision complaints and definitely moving beyond just, needing new glasses.
Yeah, the source material for this is pretty hefty. It's a big clinical standard, the NHG-Standard Visusklachten. It used to be mostly about focusing issues, refractive errors, but now it covers a whole lot more. We're talking serious acute stuff, too, things that can really threaten your sight.
Right. So our goal here is to sift through all that clinical detail and pull out the really crucial bits, like what causes vision changes at different ages, and if something's just, annoying, or if it's a real emergency. We want to get to the core of what you need to know for your eye health. Because let's unpack this, starting with the most fundamental differentiator the source points out, age.
Absolutely.
Yeah.
That age difference is, well, it's key for diagnosis. The standard basically says up to about age 65 if your vision changes. It's overwhelmingly likely just a refractive error, a focusing problem. Simple as that, usually.
But then you hit 65 and it flips.
Completely flips. After 65, vision loss is much more likely due to actual eye diseases. Things like cataracts, macular degeneration, MD, or glaucoma, structural issues.
Just knowing that single number, 65, changes how you should think about a vision complaint, doesn't it?
It really does. Changes the urgency, the potential causes, everything. But before we dive into those diseases, maybe we should quickly define what we mean by vision. Clinicians use the term visus, or visual acuity.
Right, that's the measure.
Yeah. It measures the tiniest details you can make out at a specific distance, usually 5 meters or more.
And what's considered like perfect vision on that scale?
Normal is 1.0 or better. But the scale itself is quite intuitive. Say your visus is 0.5. That literally means you need to be twice as close to see the same detail someone with 1.0 vision sees.
Okay, that makes sense, like needing to get closer to read a sign.
Exactly.
So let's cover those common focusing problems then, the refractive errors, since they're the main culprits before 65.
Sure. First up is myopia, nearsightedness. Light focuses too soon in front of the retina, often because the eyeball's a bit too long. You fix it with those minuses lenses, S correction.
And that's the one kids often get in school.
Yeah,
School myopia.
that's the one. Often pops up between 6 and 12 years old. Then there's hypermetropia, or farsightedness. Light wants to focus behind the retina. When you're young, your eye muscles can often accommodate.
They work harder to focus.
Right. But as you age, that ability fades. That's when you need the plus lenses, S plus correction.
And the one none of us escape, presbyopia.
Ah, yes, age-related farsightedness. This isn't about eyeball shape. It's the lens inside your eye getting stiffer, usually after 45 or so.
That classic holding the menu further away move.
Precisely. That needs the add strength in your glasses for close-up focus.
Okay, moving on from just focusing, the source really highlights a critical issue in kids, amblyopia, the lazy eye.
Yes. And it's crucial to understand this isn't just about alignment, it's reduced vision, often in one eye, because the brain didn't get clear signals during that vital development window.
And glasses alone won't fix it.
Not on their own, no. It's a brain development issue, triggered by poor input. And the urgency here is, well, it's immense. The source really hammers this home. Treatment works best the younger the child is. Patching the good eye, or sometimes atropine drops, it really needs to start ideally before age 7. After that, the chances of success drop significantly.
Wow. And I saw this statistic in the material that frankly surprised me. Even after successful treatment, about a quarter, 25% of kids have a relapse.
That's right, 1 in 4. It means the vision can slip back.
So it's not just treat and done. It needs real long-term watching, probably by an orthoptist.
Absolutely. Vigilance is key. Follow-up is critical. Okay, so let's shift gears now, across that 65-year-old line, into the territory of those big 3 structural diseases.
Starting with the most well-known, I guess. Cataract, cloudy lens. We hear about gradual vision loss, hazy sight, glare. Sounds awful.
It definitely can be.
Right.
But here's an interesting point from the standard. Surgery where they remove the cloudy lens and pop in an artificial one isn't automatic. It's really only recommended when the patient feels their vision isn't good enough anymore, when they're dissatisfied.
So it's patient-driven,
Yeah,
not just based on the doctor seeing a cataract.
exactly. It's about quality of life. If someone's managing, even with some cloudiness, you don't necessarily rush to operate.
Okay. Are there any other sort of less common symptoms?
Well, sometimes people get monocular double vision, seeing double in just one eye. That can happen with cataracts because the lens is irregular.
Interesting. Okay, number 2, macular degeneration, or MD. This sounds much more serious. Affects the central retina, the macula, And the source calls it the leading cause of severe vision loss in older adults in the West.
It is a major one. It hits your central vision, hard reading, recognizing faces. But your peripheral vision, seeing out of the corner of your eye, usually stays okay. Key signs are that dark spot right in the middle of your view, or maybe metamorphopsy.
Metamorphopsy, that's the wavy lines thing.
Exactly. Straight lines look bent or distorted, very characteristic.
And there are two types, dry and wet.
Correct. Dry is way more common, maybe 80% of cases. Unfortunately, there's no real treatment for dry MD right now. Wet MD is less common, but progresses faster. Thankfully, we do have treatments for wet MD, injections, vascular growth inhibitors that can slow it down.
I noticed the mention of the Amsler grid, that check-at-home chart. But what about preventing it? The source seemed pretty skeptical about supplements.
It did, for prevention. The standard is quite clear.
Yeah.
Taking general supplements like vitamin E, C, zinc, not recommended. No real proof it helps stop MD from starting. However, if someone already has MD, particularly intermediate or advanced stages, there is some limited evidence that specific high-dose supplement formulas might slow down its progression.
Okay, so it's a potential treatment aid, not a preventative measure for everyone.
Exactly, a crucial difference. And finally, the third big one, glaucoma. Often called the silent pressure or silent thief of sight.
Because it damages the optic nerve slowly.
Right.
And affects peripheral vision first.
That's right. It's chronic progressive damage to the optic nerve head. And it niggles away at your side vision gradually. Your central vision, what you use for detail, stays sharp until very late in the disease.
It makes it hard to notice yourself.
Very hard, until significant damage is done.
And the main risk factor we hear about is high eye pressure. Intraocular pressure, IOD, above 21.
That's the biggest modifiable risk factor, yes.
Yeah.
High IOD, typically over 21 millimilliNHG.
But here's where it gets really interesting. The source says nearly a third of cases happen with normal pressure.
That's normal tension glaucoma. And yes, it makes things incredibly complicated. If the main warning sign, high pressure, isn't there and there are no symptoms, how do you catch it?
That makes the screening advice pretty critical then.
Absolutely. The recommendation is clear. If you have a close family member with glaucoma, you should start getting screened around age 40, even if you have no symptoms.
That's definitely something people need to know. Okay, let's switch gears again. Let's talk flashes and floaters. Everyone seems to get these sometimes right. But when is it just annoying and when is it panic time?
Yeah, most Musha's Volantes floaters are totally normal. It's just the vitreous gel inside your eye, aging, clumping up a bit, usually harmless.
So seeing a little speck drift by, probably okay, but the source flags change is the key thing.
Exactly. The real alarm bell is a sudden shower of new floaters, lots of them, appearing quickly. Especially if they come with light flashes, like little sparks or lightning streaks, photopsy.
And that combination means?
That combination strongly suggests something called a posterior vitreous detachment, or AGVL. That's where the vitreous gel pulls away from the back of the eye, the retina.
And that pulling action can be dangerous.
It can be. In about 10 to 15% of cases where people have those symptoms, sudden floaters and flashes, that pulling causes a tear in the retina.
Oh, wow.
And a retinal tear can quickly lead to ablatia retinae, a retinal detachment. People often describe that as a shadow coming across their vision or a dark curtain closing in from the side.
And that's an absolute emergency.
Absolutely. Immediate referral, no waiting.
Okay, what about temporary vision loss? That can be terrifying.
Yeah.
How do we tell the difference between, say, a migraine aura and something much worse, like a TIA, a mini stroke? The source says speed is key.
Speed and character, yes. A migraine aura. The visual symptoms build up slowly, over 5 minutes or more. You might see shimmering lights, zigzag lines, maybe colorful patterns. The scotoma? It's dynamic, often bright, and usually lasts less than an hour.
Okay, slow onset, dynamic, bright. What about a TIA?
Completely different. TIA symptoms hit fast, in seconds, often described as a dark shade coming down, or black spots appearing suddenly. And it's static, not shimmering or changing. That sudden dark onset is the TIA warning sign.
That distinction feels life-saving.
It can be. Which leads us straight to the critical must-refer immediately symptoms, the absolute red flags. Number 1, acute vision loss. Sudden, or developing quickly over a few days. 2, sudden loss of part of your visual field, in one eye or both, like that curtain effect. 3, light flashes that don't stop or flashes that come with that visual field loss. And number 4, acute double vision. Sudden onset diplopia.
Got it. Those 4 need immediate action. No hesitation. Okay, so if someone does have a concern, who do they actually go see? The eye care world can seem a bit confusing.
It can, but the roles are quite distinct. Your optician is mainly there to measure your vision for glasses or contacts and sell them, basic measurements. The orthoptist is a specialist, often working with kids, focusing on eye muscle coordination, alignment, and treating amblyopia.
But so for that lazy eye concern in a child, the orthoptist is the go-to.
They are the primary expert there, yes. But for most adults, the key person is often the optometrist. Think of them as the primary care provider for the eyes. They do comprehensive exams, use the specialized equipment, and crucially, their job includes diagnosing or ruling out those diseases like MD and glaucoma. They can spot things beyond just needing glasses and refer on if needed.
Right, so the optometrist is often the first stop for a thorough checkup. That clarifies things. Let's quickly cover the correction options for those refractive errors we started with. Glasses are obvious, but any nuances?
Well, beyond single vision, bifocals, progressives, the source mentions computer glasses specifically. They're designed for that intermediate distance to your screen. Different focus point in the top part compared to reading glasses.
Makes sense. And contacts, hard versus soft.
Yep, the classic choice. Hard or rigid gas permeable, offer sharp vision, good for complex prescriptions, maybe lower infection risk. Soft lenses are generally more comfortable initially, but maybe a slightly higher risk of infection if not cared for properly.
But then there was this other option. Night lenses. That sounds almost sci-fi.
It's pretty clever technology. Ortho-K, or night lenses. They're hard lenses you wear only while sleeping. They gently reshape your cornea overnight. You take them out in the morning, and you can see clearly all day without any glasses or contacts. It works best for certain degrees of myopia, up to about -4.50.
Wow, temporary reshaping overnight. That's amazing.
It is. And then, of course, there's refractive surgery, permanent fixes like LASIK, using lasers to reshape the cornea, or implantable lenses either placed in front of your natural lens or replacing it entirely, like in cataract surgery.
Okay, so quite a range of options depending on the need. This has been really insightful. We've covered the age divide, the childhood urgency with amblyopia, the big three later in life, cataracts, MD, glaucoma, and crucially, those alarm symptoms like flashes and sudden vision loss. Knowing the difference between slow onset like migraine and rapid onset like TIA, that's vital.
It really is. And if we connect this to the bigger picture, what stands out is how vital timely diagnosis is. Especially, as we discussed, for diseases that creep up silently. Let's just loop back to glaucoma for a second. It really highlights the challenge.
We said high eye pressure over 21 is the main risk factor people know about.
Right. But as the source material clearly states, almost a third of people newly diagnosed with glaucoma. They have normal eye pressure when they're first checked, never had high pressure recorded.
Normal tension, glaucoma again,
Oh.
symptoms, often normal pressure.
Exactly. So this leaves us with a really challenging thought, doesn't it? If this serious sight-stealing disease often has no symptoms the patient notices, and if its main measurable risk factor, high pressure, is missing in a huge chunk of cases, how proactive should we all be about getting our optic nerves checked?
Even if we think we see perfectly, even without a family history.
Should comprehensive eye exams, looking specifically at the optic nerve, become something we all just do regularly, like a dental checkup, regardless of symptoms?
That's a very powerful question to leave our listeners with. Food for thought indeed. Thank you for that deep dive into navigating vision complaints. Really valuable information. And thank you for joining us. We'll see you next time on The Deep Dive.